Minor detail.
He did. He had had the extension. It came in just a few minutes ago. That's the second time they forgot to send us the
No,
agenda.
it's consistently not posted.
Bring the meeting back to order and take up D2, Supervisor Hammond.
Yeah, I called for Radine to give us a presentation about the meeting we had with UNR and Mr. Hallberg. I'll let Mr. Hallberg introduce Radine.
We've, Tim Hallberg with Congressman Bedwampa, spoken to you on several occasions before that we've been working on an avenue to assist rural clinics, health clinics, and hospitals with staffing of medical personnel such as physicians. And we've approached the University of Nevada School of Medicine, and they're very cooperative. They want to see this system work, and they want to help provide residents to this. And Mrs. Monte has sort of slipped in as a head of our team to help us. She's quite well qualified. Matter of fact, I have her resume. If any of you would ever like it, I'd be more than happy to forward it to you. So I'm going to let her make the presentation. She's done a tremendous amount of work as a volunteer on this, and I think you're going to well receive her. So thank you, gentlemen, very much.
Thank you.
Thank you.
Welcome.
Thank you. First of all, I want to thank and acknowledge Tim. He's the reason I'm volunteering. If any of you have spent very much time with him, you often find you get involved in projects. That's how I came to volunteer. I was working with Surprise Valley Healthcare District for a couple of months, serving as an interim assistant administrator, and that was how I got to know Tim. So he invited me to a meeting with people from, and in the handout that you received, I just want to list the membership of this group that is looking at the issue of improving access to care for veterans, and also a way to have local healthcare districts, hospitals, and clinics become more viable. So the membership included staff of the offices of Senator Dean Heller of Nevada, of course Representative LaMalfa of the 1st District, your representative, also Tom McClintock and Mark Amity of Nevada. And then we brought together also Nevada Medical School and administrators of Modoc Medical Center, and Phil is here today from Northeastern Rural Health Clinics, and Tom Hammond, thank you, a member of your Board of Supervisors. So this combination of people got together and did some brainstorming, and my job was to do some background research for the group so that we could begin to understand some of the challenges facing rural health care. You've all read the newspapers, so you probably know a lot about this, and you live here, so you know the challenges that are faced. Among those challenges are, as Tim alluded to, the limited workforce. But an important part of that workforce are the physicians. And so what happens is that medical schools tend to place physicians, the new doctors, get their residencies in larger corporate hospitals where they've got the medical school and the hospital have a long-standing good working relationship. And so the doctors get placed in this larger institution and they have a good experience and they stay there. And so they don't get exposed, they don't have the opportunity to come out to rural areas where they would be welcomed, loved, adored if they would come. They don't understand, they don't have the opportunity to meet your community. And so, in this meeting, the exciting thing is the University of Nevada Medical School is interested in figuring out a way to place doctors in some rural areas as a test. And one of the places that we're looking at, and we're pretty sure they're actually going to do it, so I don't want to just say looking at, but Northeastern Medical Clinic will have a resident, and also in Modoc County, the Modoc Medical Center will have at least one resident. We're writing a grant proposal right now to try to get the residents funded because the irony of all this is that small rural hospitals end up paying more for doctors than larger organizations. And that's because if you don't have local doctors working for you and you have a contract with a local physician, you have to hire essentially a physician's temp agency. And I'm sure that the county from time to time has had to use temp workers. And you know you have to pay that company as well as pay the worker. Consequently, a hospital can pay $30,000 a month for a physician. And it's,
How much a month?
it can be as much as $30,000 a month if you bring in what's called a locum tenens. And those are doctors who are able to work emergency rooms and do some specialty care. I mean, these are doctors that are very well qualified. And the companies, of course, have to make money because they're making all the matches for everybody and doing a lot of work that the county would have to do. So at any rate, what happens is that hospitals and clinics get hung up in trying to pay this bill, so they can't expend the money to do, they can barely meet their operating costs, many of them. You're not your clinic. Your clinic's doing fine. But there are hospitals that actually go out of business because they just can't afford to keep themselves going. There's no wiggle room. There's no operating expenses that they have to work with. The other thing they're not able to do is recruitment, because that takes a lot of negotiating. And one of the things that the larger facilities offer is assistance. It is assistance to new physicians to help them pay back their loans. Their loans are significant, and doctors really have to get loan repayment as part of the deal when they get hired somewhere. So, but the smaller hospitals don't have any money left over because they're trapped in that hiring the temp doctor thing, right? So what we've written is this concept that we'll work with at least one university medical school, find a way to place some doctors and introduce these doctors to the rural clinics and hospitals. And money that is saved through this process would then go into a fund. And we're looking at a way to establish a common fund that a variety of healthcare districts, hospitals, and clinics could put their money into this common fund that they could then draw back out as an incentive to hire physicians, to get physicians out to rural areas. So thanks to Tom Hammond's involvement, your county will be part of a pilot project where we first test these ideas. Now, in the midst of all this, another issue that we looked at is the recent legislation allows veterans to be able to use local medical facilities if they live 40 miles or more from the healthcare provider, the VA. They're able to use a local hospital. In your case, and we've handed out, do you have the handouts, or did you, I don't know if you have the maps. Okay. On the map, you'll see that because of your new, relatively new veterans facility here, it's a primary care provider, so your veterans have a clinic they can go to. If you look, you'll see that Doyle is just outside of that line. So the veterans that live in the southern part of your county don't have as easy access. And
This clinic here, but they have access to the VA hospital in Reno?
They do.
It's more than 40 miles, though, Jim.
anything,
From Doyle to
It's
Reno?
more than 40 miles, yes.
The hospital. Okay.
and the other issue is wait times. So that if a veteran is told that it will take 30 days or more to get whatever health care service he needs, he may use a local resource for that. So even if your local clinic, your VA clinic, got really busy, and right now I think they aren't, I think they're on track. But if it came to pass that they really couldn't take care of either a particular kind of problem that the veteran had, or you have to put the veteran on a waiting list for a long period of time, then they would have the alternative of using Banner or Northeastern, even though they are in the same town. So it's a really important piece of legislation, I think. And so one of the things we did was we wanted to find out how many veterans live in your community. And you have 3,500 veterans. About 25% of those have received services from any VA facility in the last year. We don't know what happened to the other 75%. And one of the things we would like to do in the grant proposal we're working on is to be able to study that, to find all the veterans and find out what their needs are and are they getting their health care needs met. And I think my time is up. I just looked at my watch. I'm sorry.
Oh, you're fine.
You got all the time you need.
Oh, well, you're very gracious. Thank you. I think that I I wanted to bring this so that the County Board of Supervisors would understand what it is that you are essentially supporting by having one of your members participate in this committee. And the promise here is it's a really exciting concept of having people find ways to fill a need for service for not only for veterans, yes for veterans, but also for the rest of the folks that live in your community. Because if we get physicians here, people are going to have easier access to get the kind of health care they need when they need it. And so we're just very excited about this project. If anyone has any questions, I'm happy to answer them, or I'm done.
I'd like to make a comment. What really started this was our effort to open, and Phil and mine's effort to open up the Doyle Clinic back up. And that led to this meeting. It's real obvious that this $30,000 per month price tag is pretty hard on. Is all the clinics? Is you're paying now? It's $30,000.
Yeah, it ranges between 25 and there's been a couple that were at 30.
And how many docs do you have on staff right now?
We are, as far as a combination of physicians and mid-levels, we're at just over 12. 12 and fractional.
Okay.
But we're too short at the very least. We really need more than that, just as a function of the additional patient needs. So it's kind of a double whammy for us.
That's okay. And in the grant proposal, I want to explain that we're asking for funding to pay the costs of providing a resident. So, because even if you were able to have a resident, then the hospital, I didn't mention this part, they pay the university to provide that resident. And that, so we're guessing that it's about half of the cost. So even if Northeastern were to pay the $15,000 or $16,000, they'd still be saving money. But in this case, we're asking that the funder pay the whole thing the first year. And after that, we begin to take that savings and not only we'll begin to recruit doctors, which will be the main thing we're trying to do, but we'll also be able to build that fund for repayment of loans.
And also, Radine, in that meeting, I think I picked up that California's got a loan forgiveness program for the residents that Nevada doesn't.
Yes.
And that's very attractive to UNR. And also, UNR is right now doubling their family practice.
They're
Correct
trying
me
to,
if I'm wrong, but
no, they're making a significant effort to more than double their residency program.
so our timing is wonderful.
The timing is right on, and they've determined that to get enough doctors in Nevada, which it's the rural atmosphere that we're concerned with, which concerns us just as well as the state of Nevada, because all of Northeast California, from our side of the mountain, is very rural. And they want to double or triple their residency program, and they're reaching out nationwide. And it's amazing. I personally had a lot of experience when my wife was ill last summer, and the quality of these residents was second to none. And they were from all over the country. They were from medical schools, from Tufts and Boston, from all over the country. It was quite amazing, besides their own school.
So in this proposal, Radine, we're talking about MODOC.
MODOC is a
Lassen.
partnership between MODOC and Lassen and the university.
And 2 counties in Nevada also.
Yes, the project will include actually 3 congressional districts, Northern California and Northern Nevada. That's the bigger project. My mind is stuck on a
I'm
particular
sorry,
grant
I
proposal
just
right now.
wanted people to understand the scope of what
The
we're talking about.
The bigger picture is all of Northern Nevada, most of Northern California. And that's the bigger group we're looking at. We found we found a small grant that we hope we'll be able to work with. And for that grant, it's MODOC Medical Center and Northeastern would receive the funds to pay the university to bring the doctors here.
And I'd like to make one more thing. Radine's doing this on a volunteer basis. So, yeah, right at this point. And God bless you for doing that for our community. Thank you very much.
Thank you. Jim?
Yes, thank you, Mr. Chairman. First of all, I want to thank Tom for having the passion he's had about this issue, and it's good that he's been involved, and I think the board fully supports his engagement this issue with you, but I do have one question. When we talk about a lot about the relationship between Lassen and Modoc, and that is in particular as it relates to UNR and the program there, and then also the healthcare being at the VA hospital there. And when I look at your map, here we have your 40-mile radius circle and so forth, and we talk about when Doyle's kind of left out, there is a pretty good population base there at Lake Almanor, which is fully within, and it's in Plumas County, which is on the other side of the line, and there is Seneca Hospital there, struggling, trying to maintain itself. I'm not sure if where Indian Valley would fit in relationship to this picture, or even Quincy. Portola obviously is outside of it. But I think it would be logical that the partnerships that we're talking about to the north and to the east are extremely valuable. But I think the partnership with the folks in Plumas County that are immediately adjacent, a fair amount of WAP's population in his district there is in Westwood, and Clear Creek, which is right on the border with Plumas County, and for the most part, those residents do get some primary care exposure when it comes to using Seneca there in Chester. But it'd be nice to be able to involve that part into this overall picture, because it would be of direct benefit to Lassen County residents. I mean, not that somebody in Westwood can't come over and use the clinic or be accessible to Banner, but in some cases it might be more immediate. Their closest, ER would be like right down the road into Chester, and at least for the initial contact, but for long-term stuff, they probably would have the benefit. And of course, there are a number of folks in Lake Alma area probably go south to Chico and tie into the healthcare through Enloe and stuff to that end. But there are people who can't go to Chico, and they would be coming our way. And I think it would be great if we could somehow provide some connectivity, or at least give choices so they could go either direction.
Thank you. We'll definitely include the people who live in Plumas County in the broader effort. But I appreciate you letting me know that now, because I happen to be meeting with someone at the hospital in Chester to also have further conversations about this. So,
but I'm thinking more as it relates to our Westwood and Clear Creek residents.
Okay.
In terms of proximity, having at least that backdoor partnership there is, I think, as far as the near-term strategy, would be very helpful as well. I mean, at one point, I think Northeastern does have a clinic. They operate in Westwood, so it's already somewhat tied into the network you've kind of created. But they obviously would have some relationship with those folks across the line.
That's good to know. Thank you.
Jim, if I could add real quick to that, basically, our concept is the entire geographic area that's administered by the Reno VA Hospital, which takes in everything you're talking about. Virtually clear to Nevada City. And the Reno Hospital has a clinic in Auburn. Then they have 2 clinics in Nevada, and then, of course, our wonderful clinic here in Susanville. But basically, we want to take in, and it just sort of went together this way. We weren't picking on anybody.
Right, I didn't realize. I wasn't suggesting that.
No, but I just wanted you to know that there's no effort to cut anybody out.
No.
This is a pilot program to start.
Our focus is obviously with Lassen, but I think that there is some correlations there. It's too bad the circle can't stretch up north and take in like Big Valley too. Because those people would definitely benefit from some additional augmentation of service.
Sure. And anything we do would include those clinics up there, which I believe are administered out of Fall River Mills, if I'm not mistaken.
Yeah, I think so. Out of Fall River.
Right. Which is a very well run organization, by the way, too.
Thank you, Tim, for the clarification. Is there any?
Yeah, a couple things I'd like to add. First of all, I want to thank you for donating your time for this. This was a great big project, and bless your heart for this. As far as the doctors go, are these doctors or physicians' assistants or just kind of?
These are physicians. They're medical residents.
Okay. And the residents, is this, when you go to the different hospitals or clinics, is this going to be like 6 weeks at a time, or is it going to be longer?
Yes. It'll be, we're actually, what we would like would be to have them come a week at a time for over several months, but that's not the traditional way of doing residencies. And their traditional model is 4 weeks at a time, all in one place at one time. So that's, in fact, one of the things we're talking about. My view is that if you could get somebody here more frequently over a longer period of time, they're more likely to make friends with everybody in town and really get invested. We're just not there yet in our negotiations.
And the reason why I asked that is my wife and I, we housed a couple of PA students, physician's assistant students that are actually from a school out in Iowa that have come and worked at the Big Valley Clinic because there was kind of a nexus and connection there. The lady that was running the chair back there or whatever. But anyway, and it is a wonderful program. Those, you get to know these young people, and they do a great job. They do a great job, and I'm very excited to see that.
Well, Aaron, and also a resident for your information is an MD. They are a medical doctor. They're licensed, and they will be licensed either in Nevada and or California. They're taking care of that aspect of it. But the beauty of it is they have the entire university staff at their beck and call. So if they have a question or they're not familiar with it, all I have to do is pick up the phone or send an email to so-and-so. So we have the entire University of Nevada School of Medicine behind this. That's, to me, the main kicker of the whole thing. And it's, by the way, an excellent medical school.
Yeah. And PA students that we've housed under that program there, the PA students, they actually had to pay to come out to work there. And I mean, it was really basically for free. If you can get a lot of this stuff knocked off to help them out, I mean, I think this was a wonderful program.
Just to let you know, I do have one map that I didn't hand out, but I'll just show you. This is the big picture of where we are. This is all of the Northern California area. These 3 red dots are where your VA medical centers are. So you can see that if someone needs a clinic, they're going to have easier access. But if they need a hospital, you can see what a long drive it is for people. So that was what got this conversation started. This, and I'll show you one more, this is where all the clinics are. And California is better covered, although, well, I won't go into the details, but it's 40 miles on the road, and of course we took a shortcut and just did a 40-mile radius, so some of the distances are greater than what you see here. But California is covered better. Nevada's really challenged, and far northern California, where we are right now, is one of the least served areas. So, and like I said, you have 3,500 veterans, and we want to be sure that every veteran has access to health care, and if not, then we can find a way to nag them to show them that there is health care available, and I'm a good nag, ask my husband, so we need to do outreach. We call it outreach.
Okay, any questions from the public? Agenda. Okay. Ms. Spencer, then Jim.
You mentioned that the cost is normally around $15,000, $16,000 a month, and could go as high as $30,000.
For placing, this is an estimate because we haven't worked it out with the university.
Per physician.
It's per medical resident. The cost of having a medical resident for a month, it could be as much as $15,000. If you hire what's called a locum tenens, that's a physician who's working for, I'll call it a temp agency. If you hire one of those folks, it costs about $30,000 a month. And yeah.
My question is that is there a negative cash flow with your program, or is there a revenue stream that would cover that $15,000 under your program?
This isn't a program yet.
This
is just a concept of trying to get people together to figure out how to make a program.
Is this part of your study to see if the revenue stream
Yes.
will be enough to at least enough to cover the $15,000, so you don't have a negative cash flow?
Yes.
Okay.
This will, by saving money, the money then that is saved can then go into other programs the hospital would like to offer, or the clinic, or into a fund so that you've got incentives to help doctors pay back their loans. because anybody, any doctor is going to need that kind of help.
And your revenue stream, where is that?
There isn't one yet.
No,
This-
where would it come from? Where do you anticipate the revenue stream coming from?
The first thing we're doing is looking for grant money to pay for the first year to cover the cost of the residents. And so the math would be each facility, there are 2 facilities, each facility would have the money all paid for 2 months out of the year. They would save $60,000. And then the second year, our thought is that they will have caught up a little bit financially so that they could pay the university for the resident in the second and third year and ongoing. And the moment, there's other savings, and we haven't done the full analysis because I don't know how many months out of the year they have to hire locum tenens, but believe me, it's a lot of money.
Thank you.
Thank you. I'll just, I can maybe add a little bit of it.
Phil, can you come to the podium and
Sorry,
introduce
yeah.
yourself so everybody?
The microphone.
This is a really good question. I think that from a taxpayer's perspective, I mean.
This is Phil from Northeastern.
Northeastern, hi.
What's your last name, Phil?
Phil Novak.
Thank you.
Okay. From the clinic standpoint, and because we're very concerned, anytime you see kind of the good news and bad news about grants, are they great when you have them and they're terrible when they run out? So as to not get into a situation where it works for maybe a year or whenever there's a grant period and then it's not sustainable. Just really, really rough math, but just to, I think, answer your question. If I look at what our average net revenue is per patient visit, putting together all the different sources, whether it's Medi-Cal or Medicare or VA, we don't, at this point, we don't see VA as far as being reimbursable, very rarely because of the clinic. Hopefully with this legislation, if there is a need, that could certainly change. But from the standpoint of a resident, let's just say, who is with us for 30 days, and they are seeing approximately the number of visits that another provider is seeing, they would more than offset the cost, even if we were truly full boat, having to pay the School of Medicine and or potentially any other university that would provide a resident to us. So, and that's whether that would be in Doyle, whether it's in Susanville or Westwood. So that's, I think, another really great part about this. It's possible to look past the honeymoon period when the money's coming.
Sustainability.
Yeah, sustainability.
Yes.
So,
Thank you.
yeah, thank you.
Good answer.
Jim?
Mr. Chairman, this particular effort, I think, really drives home real close to heart for me. Next Monday will be the 30th anniversary of my mother passing away at the VA hospital in Reno. And she was one that was very appreciative. She received excellent care. Just had a health situation that was, cards were stacked against her. But my dad, on the other hand, as a veteran, never really was interested in obtaining VA services. He had private health care that he was able to access and use. So when we talk about 3,500 veterans and how only 25% of which translates to about 875 of those veterans that are actually engaging the Veterans Administration of Services, and how we can maybe boost the numbers that translates in the fact that 2,625 veterans, are not receiving, services directly from or through the VA. But I think part of what we're going to have to do, and I think you're going to have as an obstacle, is dealing with the national press that has kind of come down fairly unfavorable on the VA in recent years, and in terms of talking about waiting lists and long lines and so forth. So you can build the capacity, but you got to demonstrate that the capacity, if all 2,625 of them showed up tomorrow at the VA office here, the clinic here, and say, we need services, I would say, I don't care how hard you bring in all these additional resources, are they going to be able to provide an immediate response? And I think that's part of the logistics that you're going to have to somehow comprehend. I mean, we've got a national concern, and I'm sure that there are a number of those folks who probably by choice have decided not to engage the VA as their health care scenario for whatever reasons, and part of it is because maybe they don't want to be the guy on the waiting list that has to wait 3 months to get his appointment, and he dies 6 weeks from now. And I mean, and those kind of stories, come through loud and clear with the social media in particular. And I think we need to make an effort. I mean, anything we can do to promote, the ability for those who have a need to engage for those services is definitely noteworthy. And I know my mom, she was very appreciative of the care that she received, and the family. We spent a lot of time there at the VA hospital before they did the major review we have over there now. And so it's something that I think we need to make a commitment to try to achieve. And even if we only gain another 5% or 10% market share, that's a huge effort. And hopefully we can do even more. And I think the fact that VA recognized the fact that they have a huge population in northeastern California by locating the clinic here when they did, was a huge step forward.
Okay, any more questions from the board?
No, I asked Jenna and Galen to be here to listen to Rudine's conceptual plan, hoping that we could get some assistance out of their grant department and maybe writing grants to assist us to get it off the ground. So,
And I would add to, Jen, what you had to say, that when the financial crisis hit, 6 years ago, thousands of people lost their jobs and lost their medical insurance coverage, and the veterans just swarmed onto the VA. And yes, there are long lines. I use the VA. I'm on a pay-as-you-go system. There are long lines. It can take 90 days to get an appointment. This is determined by the staff they have available. They're constantly trying to hire. They're very particular who they hire. So not just anybody can go in there and get a job. The beauty of this concept is it would open the door, like in Susanville, to 3 other places. You've got the clinic, number 1. You've got your private health clinic, and you've got Manor Hospital. So you're on target on that.
Oh, yeah.
And the publicity that's bad on the VA in our office is very responsible for a lot of it, I'll be very frank, is they got so overwhelmed that they were starting to hide files. This did not happen in Reno. Yes, they were behind. At one point it was 342 days to get somebody classified, but it's classification was the main problem. Once you're determined, I was diagnosed with cancer at the VA. From that moment on, it was jumped. There's nothing but a 2-day delay. They're just outstanding when it comes to that. But you're right. There's going to be long lines, but this opens the door. Like in this case, there's 3 other possibilities right here in town.
so if we can get this effort organized, won't this assist the Reno VA in some of these wait times? If we can take a little bit of the load off.
Anything like that helps
Yeah.
them. It helps them. Tremendous. They're under extreme pressure to get people through.
Yeah.
And there's a lot of us are geriatrics, believe me. But you see these youngsters in there all the time that are coming back from Afghanistan, and the mental problems. And you have access to mental health problems. I mean, there's lots of ways we can help. Actually, with mental health, we'd have an extra. Yeah, we'd have an extra asset, Melanie, with your office. So this is extremely important, and she would be able to build a VA.
And I'm sorry I left Melody out of that. She was standing behind.
Right, but she would be able to build a VA for a
But we
veteran.
succeeded in getting that special grant that allowed for those peer counselors to come in with our local county program to reach out to our veterans population, to try to bring about some connectivity to kind of bridge some of the gaps where
Right.
our local veterans weren't able to maybe get comparable services directly through the VA
Right.
arena.
And we're also in the process of getting all of the billing criteria, et cetera, and if you need any assistance on that, our office will do, we'll help you any way we can, obviously, on that. But you brought up, Jim, actually the perfect point of all of this, and what causes this to go together. Surprise Valley, everybody knows where that is. They can't pay $25,000, $30,000 a month for a doctor. There's no way at all. And we're in the process of negotiating. We don't know what the university is going to charge. but it's going to be a reasonable fee. We know that. Thanks again.
Thank you, Tim. Any questions from the public? Well, thank you people for coming. It was a great presentation. It sounds good. I hope we can get this. Thank you. I guess that concludes the meeting. Meeting adjourned.